What's up everybody, Dr. Rossi, StrengsandSneakers.com. So in this video what I want to do is go over can benzodiazepines be ethically prescribed in psychiatry. I'm going to tell you what my clinical experience has been and what I've seen from other attendings and the various settings that I've worked in. So let's go ahead and jump right into this discussion because I think it's a really important one. Over the last several years we've seen benzodiazepines getting a really bad reputation, not only from psychiatry and from other medical specialties, but also from popular media. We're hearing that benzodiazepines are sort of becoming the new opioids in terms of medication prescribing. Now, I've worked with several attendings and I've had various experiences. Some attendings see the utility and value in benzodiazepine medication, and others are completely anti-benzo. So there's a core group of psychiatrists who are now no longer using any type of benzodiazepine medications. In fact, they've gone as far as to create their clinics and their private practices as no benzos or anti-benzo prescribing clinics. So they literally prescribe no benzodiazepines, so that eliminates a whole patient population from their practice because these are going to be people who are going to avoid it based on the decision to not prescribe benzos. So let's just briefly go over benzodiazepines and how they work. So all of these medications work the same way. It doesn't matter if we're talking about Alprazolam, Lorazepam, Clonazepam, Diazepam, whatever, they all work the same way. They are going to bind to GABA A receptors and they're going to enhance the effects of GABA. So they're going to enhance the inhibitory effects of GABA, hence the reduction in anxiety that many patients experience. Now, these medications are not all equal in terms of the way, although they all work by the same mechanism, they have differences in half-life, and they also have differences in the speed of onset. So maybe the medication that gets the worst reputation is the medication Alprazolam, which has a very short half-life of 6 to 12 hours, and also the speed of onset is very rapid. It's about 30 minutes. So this is a drug you could see being, or medication you could see being very addictive with that rapid speed of onset as well as the short half-life. It's going to sort of reinforce the addictive nature or potential of that medication. So Xanax, Alprazolam, a medication that you may want to be very selective about who you use that medication with. Now the opposite end of the spectrum is clonazepam or Klonopin. Now, Klonopin has a long half-life. It's 20 to 50 hours, and its onset is somewhere between 1 to 4 hours. So what that does, or how that translates clinically, is that this is the least addictive. But the thing to keep in mind about clonazepam is that it is the most potent. So when I say it's potent, we can look at the dose equivalents to kind of understand that. So clonazepam, 1 milligram per day, so just 1 milligram per day, whether you split it up at a half milligram twice a day or just a total of 1 milligram at one point during the day, it's equivalent to Ativan or Lorazepam, 4 milligrams, and Valium, 20 milligrams. This is a very potent medication, but again has less addictive potential because of the longer half-life and the speed of onset is much slower. So that doesn't create the reinforcing effects. Now, probably the most important thing for anyone who's going to be prescribing these medications to understand is that none of these medications are for long-term management. They were never intended to be drugs that people with generalized anxiety disorder or patients with major depressive disorder with anxious distress, they were never meant for those people to be on them for long-term. But what often happens, unfortunately, in clinical practice, especially in the outpatient clinics, is you'll come across patients who have been on these medications for 20 or 30 years and maybe having some difficulties, and now you've got to try to taper them off this medication that they've been on for 20 to 30 years that has very real potential risks when you're tapering a person down. So it can be a really difficult clinical scenario for anybody working in the outpatient setting. Now, with that said, you shouldn't prescribe these all long term, so how long should one prescribe them for? Now, in general, clinically and from the research that I've been able to evaluate, I could only see prescribing these medications anywhere between 1 month and 1 week. So basically 1 to 4 weeks is your window, and you really should try to avoid having patients on these medications beyond a month. Now, if you need to, or you feel like there's reason, always remember that if you're going to extend the treatment out, make sure you reevaluate the patient, make sure you're confirming all of the original data that you got and that it's appropriate to continue this medication therapy, because there are real risks to this medication like we've detailed here, things like addictive potential, potential for overdose, and the data for these medications does not go out beyond 6 months of use. So if you're using benzodiazepines chronically for more than 6 months, you're in sort of questionable territory in terms of whether or not there's any evidence to support that use and whether or not it's going to benefit or potentially harm you. So there's no good data beyond 6 months. With that said, I do think that benzodiazepines have a place in psychiatry. I do not think that you should ever take a tool that we can use to help our patients completely away, but I think you have to be very careful how you prescribe this medication, who you prescribe this medication to, and most importantly, how long you're willing to prescribe the medication for. With that said, that concludes the video. Guys, please like and subscribe to the channel. It helps us to creating content. If you have comments or questions, drop them below and I will do my best to answer them.